Welcome, I am Terry Tropin, and today I'll be discussing the CPT Surgical Modifiers. But first, let me start out with some information about myself. I have a Master's in Healthcare Administration Informatics from the University of Maryland Global Campus, and I have RHIA and CCSP certifications. I'm also an AHIMA-approved ICD-10 trainer. I taught health information technology at Montgomery College for over 20 years. I've also written some books. I wrote these books. These are available on Amazon. I wrote a book on E&M coding, on ICD-10-CM coding, ICD-10-PCS coding, and then a little mini book on the changes for 2024. Each of these books will be updated every year. I'm waiting for the changes for 2025 so I can start on those. You can get these on Amazon. So here is what we're going to talk about during this presentation. First, what is a modifier and why do we need them? And then we have categories of modifiers. Modifiers that are more than, indicate that more than or less than the usual service were performed. Also modifiers that show that more than one procedure was performed during this surgical session. And then modifiers that indicate more than one physician was involved during the surgical session. And then one other modifier which doesn't fit into these other categories. Okay, so what is a modifier? Modifiers clarify the services and procedures performed by providers. Kind of add a little bit of extra information. Modifiers are important because they can make it so that procedures that would not be paid will get paid. They can make something reimbursed or not. If you don't use the modifier, it may not be reimbursed. Okay, so that's why they're really, really important. They're reported as 2 digits numerical codes added to a CPT code. For example, 49000-22. The 22 is the modifier. There are also HCPCS level 2 modifiers, and we're going to talk about the 2 most widely used ones of those. So here are the categories that I talked about. More than, less than usual service, modifier 22, 52, 53, 73, 74. More than one procedure, 50, 51, 59, LT, RT, those are the HCPCS modifiers that are used a lot. And 76, 77, more than one physician is involved, 62, 66, 80 through 82, and then other modifiers, that's a 63. So let's start with usual service. Each CPT code includes specific elements listed in the code. It also includes elements not listed in the code, such as opening the patient, closing the patient, administering sedation, pre-op history, physical exam, and smaller services necessary to complete the larger one. When a CPT code is approved by the CPT editorial panel, they make a little story about how this code is done, the normal, usual way this code is done. And that is what's the usual way. So these modifiers say more than that usual story was done or less than that usual story was done. Now, this involves the global surgical package, which we're not going to get into during this video, but I have a video on CPT's global surgical package, which will explain more. This goes into the global surgical package and E&M codes also that involve more than, less than, and alter the reimbursement and the code. So look at that CPT's global surgical package video. Okay, more than, less than, modifier 22. This is a more than, so more than the usual service was provided. So what does this more than mean? That means increased procedural service. It means more physician work. It was harder. It was greater risk than usual. it must be accompanied by a claim, a written report to support, well, why was this harder? Why was this riskier? And you need to do additional diagnoses that indicate, well, why was it harder? For example, E66.01, morbid obesity. So it's harder and it's riskier and it takes more time if the patient is morbidly obese. It's riskier. So here's an example. For example, a physician performed code 31300, laryngotomy with removal of tumor. The patient was morbidly obese, so the surgery took extra time and effort by the physician and was riskier. So in that case, you're going to do 31300-22. And you're going to do that extra diagnosis for morbid obesity, and you're going to send in a report saying this operation usually takes 2 hours, but because it was riskier, it took 4 hours. And the physician had to do XYZ because of the additional risk. And so that you send in a report to say why it was riskier, plus you have that extra diagnosis. Okay, modifier 52 is the opposite. This means less than the original service was, the usual service was done. The doctor does not include all of a procedure as described by a code. So here's an example, 37187, percutaneous transluminal mechanical thrombectomy, veins, including intraprocedural pharmacological thrombolytic injections and fluoroscopic guidance. Okay, one of the things about CPT codes, that one code can include a lot of different elements. So this code includes removal of a clot in a vein, that's a thrombectomy, injections of a drug to help break up the clot, and fluoroscopic guidance. So if not all these three elements were included, you're going to report 37187-52. So not everything was done, so you report the code with a -52, less than the usual service. Now the tricky part of modifier 52 is that you have to look and see if there's another code that includes the elements that were done, okay? Make sure it's not a code that includes what was done, so you wouldn't use the 52, you report that code instead. So here's an example. The physician did most of code 32604, thoracoscopy, pericardial sac with biopsy. He entered the pericardial sac but did not perform the biopsy. He's not going to report 32604, which includes thoracoscopy, pericardial sac with biopsy. Instead, he's going to report 32601, which includes the thoracoscopy, pericardial sac, but not the biopsy. So this one includes all the stuff that really was done instead of the code with the 52 modifier. So always look to see what was done before you can do the 52 modifier. So this is a little bit tricky. So here's another less than usual service, modifier 53, discontinued procedure. Don't use 53 when the procedure was discontinued before the surgery was started. So the patient may be prepped, ready to go, and then they stopped it, okay? They said, wait a minute, the power went out, or the surgeon felt he became ill, or the instruments broke and there was nothing to replace them before the surgery was started. Or the patient came in and said, you know what, I changed my mind, I don't want to do this today, okay? Or the patient was ill. So that in that case, you would not use a 53. So here are two more less than usual services. These are for outpatient hospital ambulatory surgical center procedures. 73 is the procedure was discontinued prior to administration of anesthesia. 74, procedure was discontinued after anesthesia was administered. So that's 73, 74. Okay, so here is a practice. So let me read this, pause the video for a second, see if you can figure out. I'm not asking for the code, I'm just asking which modifier, if any. So radical abdominal hysterectomy with bilateral total pelvic lymphadenectomy and para-aortic lymph node biopsy was performed on Peg Smith. The procedure took 50 minutes longer than normal because the patient experienced prolonged bleeding during the surgery. What modifier, if any, would be used in this case? Okay, let me wait a second, think about it. Okay, this is a 22, and that's because longer than usual, longer than normal. Okay, so that's the 22, right? Okay. So here's another practice. During a procedure, the patient became hypotensive and the procedure was stopped. Which modifier, if any, would be used? Think about it for a second, and then I'll talk about it. Okay, the modifier 53. The procedure was started but then discontinued because of the patient's hypotensive. So discontinued. Okay, so that's the procedures more than, less than the usual service. So now we're going to talk about modifiers when more than one physician was involved in the procedure. These modifiers are 62, 66, 80, 81, and 82. So two surgeons. The title of the modifier is two surgeons. We usually think of it as co-surgeons. Modifier 66, surgical team, and 80, 81, and 82, assistant surgeon. Why will that not go further? Isn't that, oh, here we go. Why that repeated itself? I don't know. Okay, let's talk about two surgeons, modifier 62. So two surgeons are working together as surgeons, as co-surgeons equals. They're each doing part of the procedure. Usually each doctor has a different specialty. Each surgeon reports the same surgical code and adds a modifier 62. For example, 32503-62. So, as I said before, CPT codes often include a lot of stuff within one code. So one physician is doing part of what's in the code and the other physician is doing another part of what's in the code. So they both report the same code with the modifier 62. And each surgeon will dictate his or her portion of the procedure. Modifier 66 is a surgical team that has 3 or more physicians with various specialties as a surgical team, and you've got technicians and other support personnel also involved. Each physician reports the same code with the modifier 66. This is usual for complex procedures such as heart transplant. You got a lot of different physicians involved in that. It's very complicated. Payers may increase the payment 50% divided among the 3 or more physicians involved. So that's some physicians, more than physicians, co-surgeons, surgical team. This is assistant surgeons. Assistant surgeons provide minimal assistance, such as opening, closing the patients, handing instruments to the primary physicians. They're not doing part of the CPT code, they're helpers. They don't provide a distinct separate part of the procedure, as in the ones we just talked about. The primary physician does not use a modifier. The assistant physician uses a modifier in most cases. So the primary physician is not adding a modifier, only the assistant is using a modifier. So let's talk about 80 and 81 assistant surgeon. 80 reimbursed about 15-30%. Payers identify procedures for which they will reimburse the assistant. Medicare is very specific about we will accept an assistant surgeon for this code, but not for that one. So, and other payers will do the same thing. Not all codes will accept an assistant surgeon. 81 is minimal assistant surgeon, a level less than assistant surgeon. So reimbursed in 10%, if at all. Sometimes it's just like, thank you very much, but we're not paying you. So 82 assistant surgeon. This is used only in teaching hospitals. These are hospitals with medical schools associated with universities. If the hospital has a resident who assisted as part of his or her education, no fee, no modifier 82. The idea is that the assistance is part of the resident's education and therefore not reimbursed separately. That's, thank you that, that's part of your education. I hope you learned something from doing this. Thank you very much. We're not paying you extra. If there was no resident was available to assist and someone else had to come, another physician had to come in as an assistant surgeon, there will be payment and use a modifier 82. They must document in writing that no qualified resident was available, so they had to bring in another physician. It has to be documented in a written report. Okay, so here's an example. Dr. Smith is a resident at a teaching hospital associated with Midwest University. He assists Dr. Jones in a surgery. He does not report a code with modifier 82 since this is part of his education. Dr. Smith and the other residents at Midwest University are busy with other surgeries when Dr. Jones needs an assistant. Dr. Thompson, another physician, assisted Dr. Jones instead. She reports the same code as Dr. Jones with the modifier 82. Dr. Jones documents that no qualified resident was available. So you see the difference between these. Dr. Smith is a resident, so he doesn't report the code with 82 because this is his education. Dr. Thompson, on the other hand, is a physician, so she gets to report a modifier 82, but they have to document that there was no resident around to help in this case. So here's another practice. Dr. Pearl needed surgery to insert a pacemaker. Dr. Johnson made the decision and created the generator pocket. At this point in the procedure, Dr. Hyder inserted the atrial electrode and programmed the pacemaker. The electrode was tested, and then Dr. Johnson closed the incision. Which modifier, if any, does Dr. Hyder use? Which modifier, if any, does Dr. Johnson use? Okay, they're both, this is a co-surgery. Each provider reports the same code with a 62 modifier, insertion of the pacemaker. Dr. Johnson, the incision created the generator pocket and then closed. Dr. Hyder inserted the electrode, programmed the pacemaker. So they're each doing part of the procedure. Okay, here's another practice. Dr. Daniels underwent the repair of some complex cardiac anomalies by the modified Fontan procedure. It was also necessary to perform a cavopulmonary anastomosis to a secondary superior vena cava. Dr. Smith, Reagan, Thompson, and Ames, cardiothoracic surgeons, worked together to perform this surgery. Which modifier, if any, do these physicians use? Sounds complicated. Each physician reports the same code with the modifier 66. This is surgical team. Here's the last one for this category. Dr. Barton performed an anastomosis on the extrahepatic biliary ducts and gastrointestinal tract. Dr. Carey assisted Dr. Barton with this procedure, opening and closing the patient and handing the instruments to Dr. Barton. Dr. Barton reports the CPT code without a modifier. Dr. Carey reports the CPT code with a modifier. Okay, modifier 80. So this is no modifier, modifier. Okay. So I kind of gave the answer on that one. Sorry about that. Okay, so now we've talked about more than, less than, more than one physician. Now we're talking about more than one procedure. Usually on the same day, you have 50 bilateral procedures, 51 multiple procedures, 59 distinct procedures, LT, RT, 76, and 77. Okay, we'll start with 50. This is the simplest. This modifier is used to indicate a procedure was bilateral, done on both sides. Often, this is something to check for. There'll be a parenthetical under the code that will indicate a modifier 50 is used, or that a modifier 50 is not used. So that's important. So check under your code if you think that's going to be a possibility. For example, 36100, introduction of needle, intracatheter, carotid, or vertebral artery. There's a parenthetical for bilateral procedures. Report 36100 with modifier 50. So there you go. Easy peasy. So in order to use modifier 50, it must involve 2 organs, 2 kidneys, 2 lungs, such as that. Cannot use for 2 sides of the same organ. Can't you like left side of the heart and right side of the heart? It's got to be 2 distinct organs. Do not use modifier 50 if surgery is performed on 2 sides of the same organ, or if a code description indicates it is already bilateral. For example, 55200, fasciotomy, cannulization with or without incision of vas, unilateral or bilateral. You're not going to use a modifier 50 for that, because that already says that it's used bilateral. If the code is an add-on code, for example, and this is somewhat confusing, removal and replacement of ureteral stents 50382 with bilateral endoluminal biopsy of ureter 50606, the add-on code. Stents and biopsies were both performed bilaterally. For the stents, you do 50382-50. For each biopsy, 50606, 50606, the add-on code. So you report that twice. Okay. So you've got the stents, use the 52, the add-on codes you just report it twice. It says each biopsy. So that's why you do it twice instead. Okay, modifier 51 indicates that one procedure was performed during more than one procedure was performed during the same surgical session. Report the primary, the highest paid code first without a modifier, and then report the second, third code next with the modifier 51. Why is that? Why does that matter? Well, the primary highest paid code first, that's because that one will be paid at the full amount. The second, third, fourth code will be paid at a reduced amount. Why is that? That doesn't seem fair. Well, that's because generally there's only one opening, one closing, one prepping, one pre-surgical history and exam, one follow-up. So it's not double everything. So the second, third, fourth will get paid at a slightly lesser amount. So be sure to use the primary code, the highest paying code first. Okay, modifier 59. This is the one that's really tricky. So the title is distinct procedure. It is most commonly used when it appears that one procedure might be considered part of a larger one, but in this specific case, it is not. This is because the 2 procedures are different session, different encounter on the same day. It's a different procedure, it's a different site, separate incision, excision, lesion, or injury, or most commonly, it's a separate procedure code. And we'll talk about that in a minute. And I talk about this extensively in my video on the global package, if you want to get more information about this. So this goes into separate procedure code. Now sometimes, as you probably know, after a code, there'll be the wording parentheses separate procedure after the code description. This means they're incidental to the more major related procedure. For example, a breast biopsy 19100, separate procedure, performed alone, go ahead and code it. On the other hand, if you do a breast biopsy 19100 on the same day, the same surgical session as a radical mastectomy 19305, you're not going to report the biopsy separately. Obviously, the radical mastectomy is the bigger procedure, so the biopsy is like, unimportant. So that's how this is figured. This is a separate procedure. So if it's the only one performed, you're going to report it. If it's performed with a related procedure in the same area, you're not going to report it separately. So here's some examples. A physician performed these procedures on a patient's left foot. 28110, partial excision, 5th metatarsal head. This is the 5th. And this is a separate procedure. 28111, ostectomy, complete, 1st metatarsal head. Well, obviously, those are different areas, right? But since this one is a separate procedure, you're going to have to do 28111 and 28110 59. If you don't do the 59 modifier, it's not going to be paid because the payer's computer will say, "What? It's a second procedure. We're not going to pay it," and they'll throw it out. But because there are different areas, different sites, it can be paid. One is a separate procedure. The 5th metatarsal is different than the 1st metatarsal. And it would help if each one is linked to a different diagnosis code, but you could have, I would have exactly the same problem in each, maybe, possibly. Why is it doing that? Come on. There you go. Seems to get stuck sometimes. Okay, on the other hand, if a physician documented these procedures both performed on the left foot, 28114, ostectomy, complete excision, and metatarsal, all metatarsal heads, all 5, and 28110, partial excision, 5th metatarsal head. Well, the 5th is included in all, right? All is 1, 2, 3, 4, 5, and 5th is 5. So in this case, you report only 28114. Okay. So you're not going to report the separate procedure code this time. Okay. Does that make sense? I hope so. So you have to really think about the 59 modifier. It's confusing. Okay. RTLT. These are Hicks-Picks modifiers, but they're very important. Sometimes they're use these instead of a modifier 59. They sometimes make a lot more sense. Right side, left side, obviously. So here's an example of those. 28114, ostectomy, complete excision, all metatarsal heads, everything on the right foot. And then 28110, ostectomy, partial excision, 5th metatarsal head on the left foot. Okay, and the separate procedure. So that way, that makes a lot of sense. So you can do 28114 RT and 28110 LT. Okay, even though this one is a separate procedure, if you have RT, LT, well, that shows you right away that they're different feet. Okay, so RT, LT can do a lot to clarify this stuff. It's so weird. Okay, so here's another example. Dr. Jones performed removal of impacted cerumen on both ears using binocular microscope and handheld speculum. She reported 69210, removal of impacted cerumen requiring instrumentation, unilateral. Which modifier, if any, would be used? modifier 50 because it says both ears, right? Okay, the physician performed a ureterotomy with drainage. He also took a biopsy of the urethra because of a suspicious mass. He reported 50600, ureterotomy with exploration of drainage, separate procedure, and 53200, biopsy of urethra. The important thing to remember here is this is the ureter and this is the urethra. Which modifiers, if any, would he use? Okay, this one is a separate procedure. But obviously the ureter and the urethra are different. Different organs, different diagnoses. 53200, 50600. Notice that the 59 is always on the procedure that's a separate procedure. Okay, I don't know if I said that before. Okay, one last modifier which doesn't really fit in any of these categories. Modifier 63, procedure performed on infant less than 6 kilograms, about 8.8 pounds. So if the infant is really little, it's higher risk, it's harder. So there's a modifier to indicate that. Okay, so that's what we've got. If you'd like a copy of the slides for this video, send me a note with your email. My email address is right here. Remember my books on Amazon. They will be updated. Here's the 2024 versions. They'll be updated for 2025 when I get the information. It's not out yet. If you have questions, let me know. Here's my Facebook page. And you can get all my books on Amazon. If you want more information on modifiers, see the video on the global surgical package. I'll put the link to that on here so that you can see that too. Thank you so much for listening. I hope this was helpful. Thank you.